Very good afternoon to one and all of you. I think some of our probable audience are in a state of slumber. That's why we have fewer here. But we will give our life to this course, and we are there to clear any of the doubts which you have, if we do have enough time for that. I would request Gaurav also to keep his talk within the time limit. I would want the timer to be on, please, for all our speakers, so that we do have time to discuss some important questions which I've kept for you all to be discussed, and anything which may come up along the way. I'm sure Dr. Gaurav needs no introduction. He's the director of the Drishti Eye Hospital, Dehradun. He's the chairman ARC of IRSI, and an extremely popular dynamic cataract and refractive surgeon. And I'm truly lucky to have him with me in my course. And he's going to be talking. 8 minutes. 8 minutes. And he would be dealing on update on epithelial mapping and their relevance in refractive surgery standpoint. On to you.
Thanks. Thank you, Dr. Chitra, and very good afternoon, everyone. I think it's a privilege to be in Dr. Chitra's course for the last couple of years. It's been very interesting. So, ma'am has asked me to speak on epithelial thickness mapping, which has been very close to my heart all these years. We started doing this about 6-7 years back, and ever since it's become almost as invaluable as a topographer or a pentacam for our refractive surgery workups and follow-ups both. So the epithelium thickness mapping came about when OCTs started getting better and better, and once the OCTs were able to pick up the epithelium, then it became much easier, because then they had to just do the checking whether it was a predictable and reliable thing, and then they found that it was pretty predictable. So the one which I've been using is the Avanti RT View, but the others like the MS39, which is newer, and even the Cirrus now, they have excellent epithelium thickness mapping abilities. And so these studies were done by Dan Reinstein, and they found that the range of error for the automated epithelium thickness mapping was very, very small and comparable to what was in the gold standard of the manual measurements of the epithelium thickness based on the OCT. And this was the repeatability which was reported by David Huang et al. And also patients with keratoconus, you could see that the thing was equally predictable when picking up keratoconus, where the epithelium where the epithelium changes, which I'll show you how it changes. So this is the normal eye, and average corneal thickness is about 50 microns, but it can give you a surprise. Sometimes I've actually seen corneas with 470 or 480 pachymetry, and then corneal epithelium thickness of 55. And on the other hand, so you cannot generalize, and when we do feed, especially for those of us who are doing trans PRK, if we feed epithelium thickness without checking it on OCT, we can actually go wrong by quite a big way. And there are corneas which are thick, and maybe 600, and you may have a epithelium thickness of just about 49 or 50 microns as well. And these may be all normal. So post laser vision correction, epithelium thickness changes have to be documented, and they actually tell us a lot about how the refractive surgery went off. And you can have post LASIK, if you are doing a myopic LASIK, you will obviously see a central epithelial hyperplasia because of the remodeling. And with PRKs as well, you will see the similar change, but you may in the early days of PRK see different epithelium healing responses, where the epithelium may be very thin to begin with and gradually builds up. And all this helps in understanding how the healing response to various kinds of refractive surgery are. Now the other area where the epithelium mapping becomes really useful is in suspect corneas, where you are trying to see if there is a possibility of a keratoconus. So obviously in frank keratoconus over the area of the apex, which means that the thinnest pachy, you will have thinning of the epithelium as well. And you will have compensatory hypertrophy in the areas around it, or exactly opposite to that, and that will tell you about keratoconus. And let's see that this is a more advanced case of keratoconus, where this is the thinnest pachymetry of the cornea. And you'll see that this is also the area where, because of the cone, the epithelium compensatorily gets thinner as well, because of the the tip of the cone, and then you have compensatory hypertrophy. So this is a very typical pattern of what you will see in the epithelium thickness maps. But these are those established maps, and in very subtle maps you'll actually see a very subtle change, and you may actually not pick up any kind of deviation on the pentacam maps or even on the topography maps, but you may be able to pick up subtle changes like this with a little bit of epithelial thinning on the cone and compensatory hypertrophy around, so that the surface remains smooth for the placid or topographer, but the OCT picks up these early changes, and that's where the value of the OCT lies. Now, this is another patient with a central, ortho K induced epithelial thinning, and post refractive surgery, as I said, post hyperopic LASIK, the change will be totally different. And in fact, sometimes if you are suspicious of somebody having undergone a refractive surgery, a good idea, especially if somebody has refractive surgery for small errors and is not being picked up very clearly on topography or on pentacam, the epithelium maps will give away, and you will see the difference in the epithelium thickness mapping. So if you're not sure whether somebody has given you a correct history of refractive surgery or not, this can again be a very useful tool in picking up as well. So in hyperopia, you'll actually see that there is, because all the laser ablation happens in the paracentral area, you will have compensatory thinning in the center, and you'll have hypertrophy, epithelial hyperplasia in the area of the gut ring, which is induced by the hyperopic corrections. So it's exactly opposite of what you would see with myopic LASIK, and this is obviously myopic PRK, where you'll again see hyperplasia in the central zone of the optical zone, and some compensatory hypoplasia all around. So this is reverse of what you will see with hypermetropic ablations. So these are of course the stromal maps, which you can also derive once you've removed the epithelium thickness from the full pachymetry maps. The newer versions of the software allow you to actually get a stromal map as well, which again is very useful to differentiate from, once you've subtracted the epithelium changes, you can actually see whether the stromal or the Bowman's topography is actually good or not, because that can tell you a different story. And many corneas which appear to be suspicious otherwise because of epithelial changes may actually not be suspicious, and you may be able to pick up those and not unnecessarily deny a refractive surgery to a patient who only has epithelial changes rather than actual suspicious cornea. So this is again a patient where you will differentiate corneal warpage, and these are not unusual to see even when you tell patients to come post contact lens, stop using contact lens for a week or 10 days. You may still pick up warpage, and you sometimes have to put these patients on almost a month of contact lenses before the cornea actually comes to their virgin state. And as compared to this, the keratoconic corneas will show epithelial thinning in the central area and near the apex, whereas here you'll see epithelial hyperplasia. So the two have to be differentiated because on topography they may look similar. So dry eye has not really shown much about epithelium mapping. Can go either way. You can have hyperplasias and you can have epithelial thinning. So there's not much that I will be able to add here, but the applications of epithelial thickness mapping are tremendous, and especially our post CXL follow-ups, post refractive surgery follow-ups. Besides decision making for refractive surgery, it can be very useful. So this was a patient where you can see that the left eye there was a skew with the steepening, and we picked up on the Bellin maps as well. There was anterior changes on the cornea on the front anterior maps, and this was on the left eye, which was obviously showing up more changes on the front surface than on the back. And when we went ahead and did the epithelium maps, you can see that the right eye and the left eye shows a clear situation where there is a possible ectasia because of the thinning over the area of the apex. And here you can see the compensatory hypertrophy instead. You're not seeing much thinning except maybe a small island here. So both these eyes are definitely not healthy corneas. They are both suspect corneas, and this really helps you in making sure that doubly sure if you are picking up something, and if you're not picking up anything, then kind of gives you some room for doing some other surgery. So refractive surprises, I think I've used epithelium mapping has been really useful tool, because I was discussing with Dr. Chitra, I wanted to show maps here of some of our SMILE patients. Now in SMILE, we've seen that the epithelium remodeling is very different. I couldn't download them because there's no internet here, and I was trying to get mails from my clinic, but couldn't get them. Here I would like to point out that 2 weeks back, we had a SMILE patient who's almost 6 weeks post-op, continues to show a hyperopic surprise of about plus 0.5 to 1 diopter, and patient is very concerned that he's not able to see well and not read well at all. And we, as usual, would do our epithelium maps, and to our surprise, we found that the typical remodeling, which is expected at 6 weeks, with some amount of epithelial hyperplasia already happening in the central zone of the flattening, has not even started yet. So the epithelium maps were identical to the pre-op maps, which means that 50 microns pre-op and even 50 microns now. Typically at this point, if I had done a 5 or 6 diopter ablation for a SMILE, I would have seen maps showing about 55 to 56 microns or even more of hyperplasia, and that is the thing which regresses the hyperopic shift, which is seen immediately post-op. So this can help us monitor these patients. I'll finish in 30 seconds, ma'am. So again, for surface ablations, some of these surface ablations, when they're healing, the healing can be very variable. So some people will have epithelium remodeling happening very fast, and others will have a slow one. And some of them, when the epithelium is closed, you remove the contact lens, they still come in at about 1 month saying that they are not clear. And if you do their epithelium maps, you'll find that there's that fracture line where the epithelium has healed, and where you have a central linear line of fusion, and they will have high astigmatism, and some of them will not be good. So you just have to reassure them, put them on more lubricants, and allow them to settle down, and they will all settle down. So it's very easy to explain patients and yourself if you're getting some kind of unusual post-refractive surgery situations. And also lastly, enhancement planning. If you have enhancement like this, you know that you have central steepening of epithelial hyperplasia. You cannot do trans PRK, so you have to keep that in mind, and ensure that you do a brush assisted removal or alcohol assisted removal. Otherwise, you'll end up with a bigger surprise as well. So I think I was able to convey the message, and I'll stop here for the next speaker. Thank you.
That was a very useful talk, and that definitely told us about the roles of epithelial mapping. I have 2 questions for you. Do you use epithelial thickness map as a screening tool regularly before LASIK, more so for cases of borderline topographic changes?
I use it for every patient for refractive surgery planning.
Yeah.
Absolutely.
And what would stop you from doing LASIK for those patients?
So, sometimes you'll pick up corneas which are suspect on maybe a pentacam, and then you'll want to double check them on the epithelium maps. Many times the epithelium map will show that they are pristine, and some of these bad maps are actually showing up false alarms. So then you can kind of look them up further and see that if all the other modalities are showing that there's nothing wrong and just the bad maps are looking suspicious, you may still go ahead with the refractive surgery. On the other hand, you may have a cornea which shows up kind of a asymmetric bow tie or a small steeper inferior steepening, and you may be wondering whether this is, so the epithelium maps help you decide whether this way or that. So it's like a second check on all these patients, and whenever you have suspicion. Of course, there are pentacams which are absolutely clear, and you may not have much value from the epithelium maps there actually.
Now, in case of a post-myopic ablation, I'll ask you, Shrey, needing enhancement with epithelial hyperplasia as seen on AIOC2022, would you like to follow up this patient with serial maps to look for stability? I'm asking you. Or would you do enhancement? Or would you want to do a PTK and then plan a refractive correction later?
I think a couple of points. One, wonderful presentation, sir, great maps. And quickly about the enhancement part, I would definitely say where compensatory epithelial hyperplasia has a major role in small regressions, you would definitely have to wait to ensure that it is stable. But more importantly, when you treat them, how do you go about treating them is actually a major challenge, especially in late regressions, not in early regressions, but late regressions. There, the epithelium has been stable for some time, and if we ablate transepithelial PTK, and we end up, let's say, the scan which you showed, very classical 72, 74 microns, there is about couple of diopters of myopia induced by the epithelium itself. So if we just remove the epithelium, when it grows back, how much will it grow back to is an unpredictable factor. So what I would do would be a 2-stage thing. I would remove the epithelium first, allow it to stabilize over the next 4 to 6 months, and if there is a residual error, then do a PRK for that residual error. But very often it goes away with just that, and I've had patients with just pure astigmatism also where it goes away with that, sir.
I have a question to both of you. How many, you don't have the machine, but for you, if you have epithelial thickness mapping and we say that's regression, etc., etc., has anybody correlated this with ocular hysteresis?
So it doesn't correlate at all, sir. I mean, forget regression. Even patients with ectasia, it does not correlate extremely well, sir. Very advanced ectasia, yes, easily. But early ectasias, it doesn't correlate at all, sir. In fact, even on the, I have a slightly contrarian view on epithelial thickness as a screening tool also. While what sir showed were classical maps where you had the typical thinning at the apex and around the base of the cone where there is thickening. There has to be a sufficient change in curvature for such epithelial changes to manifest, sir. When we are talking about very, very subtle changes and minor ISA symmetry, where the curvatural change is not very significant, the actual change in the epithelial thickness map will be in the range of 1 to 2 microns. And there are a lot of things which affect epithelial thickness, not just this thing. If there's a contact lens wearer, there's some dry eye issues, so many other things which change epithelium, that I find that while it is corroboratory, it is difficult to use it as a standalone screening tool at this point of time.
Yes.
I agree.
Yes. Thanks, Gaurav, and thanks, Shreyesh. And we would take your doubts as time moves on. Because of similar talk, I thought I would take my talk as a second talk. And I would be taking you on enhancements for regressions and the difference defines treatment. Essentially, we all need to know that regressions is a multifactorial in the sense you find regressions if you have a high refractive error. You could find regressions if there's a thin residual stromal bed, if you have used smaller optic zones, if you're treating higher astigmatism, if you're treating older age group patients, if there is a dry eye status which has not been detected, and also if there is a change in the axial length and there has been a myopic shift in these eyes, and also a latent hyperopia which gets unraveled and there are some lenticular shifts. The other aspects to be looked at in regression is the amount of epithelial hyperplasia and the remodeling that has occurred. The inflammatory cascade itself is known to trigger greater epithelial response. The altered re-innervation which occurs in these dry eye status can trigger regression. And the steeper gradients which are getting created by the high myopic corrections, high astigmatism, and hyperopic corrections are known to increase epithelial response. And the stromal biomechanical response is also to be noted, like in these thinned out corneas and the reduced tensile strength, because of which you see a forward protrusion of the posterior lamellae and an apparent myopic shift which presents. And that is why there is even a thought of temporarily treating these eyes with IOP lowering drugs, but we really do not know how effective it is. Regression is also seen in those earlier days of using those microkeratome meniscus flaps, and it is seen that it is seen more in meniscus flaps than against the planar architecture. The architecture itself is a factor for epithelial remodeling to be different, and surface ablations in high corrections. And in fact, we have seen in different studies that the rate of regression in LASIK versus SMILE is anything from 5 to 28%, compared to SMILE, which is about less than 2.9%. Having understood the different responses and the factors which trigger regression, what do? So we first need to do a slit lamp evaluation and look whether you are able to define the flap edge. Do you think the flap edge is very fibrosed, which would tell us that it might be difficult to lift the flap? Does the flap look centered, which would tell us whether we are going to lift the flap again? A decentered flap we wouldn't lift. You would also like to look at the hinge. How does the hinge look? Is it low hinge? You would like to do the topography to see whether the corneal thickness is good, whether there is any pachymetric progression which is cluing you that it might be something more sinister. Is the surface regular? The asymmetric bow tie, inferior steepening, look at the Q value. And of course, an anterior and posterior floats, because constantly we can't presume regression if there is ectasia underlying. It makes sense to also look at the pupil size, the optic zone, what is the higher order aberrations induced, the point spread function, because we might veer to think towards a topo-guided regularization of those topographies if some other issue is there. And again, it is also important to do the epithelial map, which might tell us when you're doing a surface ablation, how much epithelium are you going to remove. Biometry will help you to know whether there has been an elongation of the eye. AIOC will tell us whether the flap thickness is uniform. We'll give you an idea whether you're going to lift the flaps. Again, dry eye status evaluation is mandatory, because if the eye is severely dry, then we would like to treat it before we do an enhancement. So the options are all of these. I'm not going to name them. So when and where? So when would we do flap lift? I would say ideally it should be best done within 3 years as the outer limit, and it's important that we define the flap edge and try to lift the flap in a very smooth manner without disrupting the epithelium, because we do not want to seed in epithelial nests. Again, it is important that the ablation should be safe, absolutely centered. And we should try to avoid lifting thinner flaps, which you can see on AIOC2022. If there is a buttonholing or a regular flap or a low hinge, we just do not lift those flaps. But if the flap lift for some reason is being considered beyond 3 years, it is important that we debride the epithelium a little beyond the flap margin all around. Again, if the flap is to be recut, if the original flap is decentered, then we would rather, what we could do is, which Kumar has a wonderful video, where he had created a deeper cut of a larger diameter if the corneal thickness would allow. You could do a mini flap over the primary LASIK if the flap thickness is good. But if the plane of cut is different, you could actually end up with flap fragmentation, loss of BCVA, and flap cut should be kept as a last resort. Surface ablations is very safe. You could do a wavefront optimized indicated cases, topo guided indicated cases. It makes sense to incorporate the epithelial thickness and customize your PRK. Mitomycin usage is absolutely mandatory, and you could combine it with low fluence cross-linking in those borderline cases or hyperopic ablations. Again, surface ablation has a wonderful role, post-smile, post-RK, complicated primary LASIK procedures. Always we combine it with MMC. But let's remember, if it was a primary flap was thin and you do an PRK, you could notice those microstriae appearing on the undersurface. And again, the post-op regimen is as similar as surface ablation, placing basial, topical steroid drops, adequate lubricants. And in case there's a delayed epithelial healing, you would delay your medical management. When it comes to smile, now what is the thickness of the cap? What is the thickness of the underlying bed? Those are going to be important criteria. And also, does the patient desire to remain flapless is a thing to be considered. When you're doing enhancement post-smile, you could think of doing a PRK. You could think of doing a thin flap LASIK if the initial cap is at least 120, 130 micron. You could do a smile, which is done in a very limited way, anterior to the primary smile or posterior to it. Or you could do a circle software, or if very high residual because of increase in axial length, you do a phakic IOL. There's nothing much to talk about PRK because as I had earlier alluded, it could be either optimized or topo guided. And you definitely need anterior segment OCT inputs are needed. And thin flap LASIK, again, we should remember that it should not impinge on the original interface, and it should be taken that a gas bubble breakthrough does not occur or a buttonhole does not occur. We need to be conscious about that. Secondary smile, I personally have a very limited experience. I was hoping Dr. Sri Ganesh would be there. He has done some secondary smile. The other option is you can convert the smile to a flap. How you can do is you can use a circle software. In circle software, there are 4 ways of doing it. Either you create a lamellar rim and a junction cut and a side cut, and then you can go ahead and do it. I'm going to show you the video. How you go about it is you first create a lamellar ring where in the dimension of a flap cut, and then once a ring is created, then you would lift up the flap. The ways are either you could create a pocket above the ring, above the flap to be created, or below, or on the same level. But the D approach has been found to be the best approach, wherein you create the lamellar ring in the same level as the primary surgical procedure. And then this is the way you would lift the flap. And then you would do the laser ablation as you would routinely do, turn the flap back and do the laser ablation. So basically, when we talk of regressions post-smile, as I said, you could think of doing a thin flap LASIK if the cap is thick. Otherwise, you could do a PRK or convert the cap to a flap with the circle software with the D approach. And phakic IOLs, very rarely it might have been needed if there is a large residual error because of progression of myopia. The complications which are to be anticipated is you could have an epithelial ingrowth. You would have to then strategize your treatment protocols accordingly. You might be prepared for haze post-regression, and you need to use mitomycin and topical steroid drops adequately. You should beware of ectasia. DLK again could be anticipated. Rarely you could have infections, and increased dry eye status should be looked out for. We need to counter it, which could have been the primary cause for the regression. So I would like to conclude stating that yes, modern days regressions are less because we are very, very careful in our selection of cases and we are very critical about it. But it needs to be well investigated, and if so, and if we do it the proper way, regressions can be definitely well managed. Thank you. Any questions for the audience you have before our next speaker could be? Yes. Any questions?
What is your enhancement rate in smile compared to LASIK and PRK?
Actually, we are very selective. Like any corneal-based procedures is only less than 9 diopters, and high cylinders we don't do SMILE, we do contour LASIK. So based on that, we have actually not calculated, but there are very few cases where we have gone and done an enhancement compared to what LASIK we used, the regressions we've had earlier. Even in LASIK, our regressions have gone down dramatically because of our very stringent selection criteria. So I think earlier days we were treating higher parts than the corneal thickness would allow. And nowadays, at the drop of the hat, we shift to phakic IOL if the corneal thickness is suspect. Your thoughts on that?
Yeah, so our enhancement rates on SMILE are very, very low as compared to LASIK. Somehow, even with high corrections, we've seen like 7 or 8 or 9 diopters. We are seeing less enhancement rates. Early days when we started doing SMILE, we had a few hyperopic surprises, which now are sorted because they were more to do with the energy and everything, but now we don't. And what about ectasia, like post-SMILE ectasia versus post? Because now you have good numbers.
Yes. Post-SMILE ectasia, it is not, ectasia in general is less, whether we do femtolasic or SMILE or anything, because our way of identifying ectasia has become phenomenal. But having said that, absolutely normal topographies, even in SMILE, we've had those surprises wherein we have not waited exactly. We've just gone ahead and done a cross-linking for these eyes just as we would have done in LASIK. Shresh wants to add something?
No, I think SMILE ectasia, LASIK ectasia, I don't think there is any difference at this point of time to suggest any alteration in our screening criteria. So when a patient is a contraindication for LASIK, he's a contraindication for SMILE as well. That's the only thing I'd like to add.
Yeah.
What's the cutoff of all of you on the panel on the bed minimum for SMILE?
Minimum for any refractive surgery, we would definitely leave minimum 300 micron.
I mean the cap, sorry. The question is the cap.
The cap thickness.
Yeah.
The cap thickness, I would keep it as 110, and I have brought it to 100 when I've treated a little high myopic correction, but never 90% is 110.
Is 120 microns, and I reduce it up to 100 microns if I want to improve the residual bed. But I like to keep a residual bed of at least 280, preferably 300.
Ganesh, I have a quick question because this is always a dilemma. Would you rather have extra 20 microns on the cap or on the bed?
Right now, I think it's more on the bed.
On the bed.
The cap, because see, Dan Reinstein has published he keeps 135 microns. But the thing is, once you kind of make that incision, it never kind of heals. So I would rather have it on the bed, though the anterior corneal fibers are stronger, but once you have that separation, then I think the strength comes down to some extent. And don't go by mathematical modelings, because we have done in our 10,000 cases of SMILE, we have had ectasias, and of course cross-linking does help, but ectasia is, see, when we talk about biomechanics, we're just looking at incidence of ectasia, but ectasia is a pathology. So if you have ectasia, whether it's LASIK, SMILE, PRK, you will still progress. If you have keratoconus, early keratoconus, it's going to progress to ectasia. The only reason you want to do cross-linking is for stabilizing the cornea to some extent. If it's kind of borderline, if you're suspect on topography, you don't know the decision, but if it's like abortive keratoconus or form frustrated keratoconus, then probably a phakic IOL will be much better.
Even in patients who have pristine tomography, pristine Corvis, biomechanics, whatever screening tools we have today, there are still patients in the postoperative period, either because of a mild dry eye or whatever be the reasons, who definitely incidence of eye rubbing, the subclinical inflammation starts going up, and that kind of becomes a vicious cycle for onset of ectasia, which whatever screening tool we use may not be able to detect to the
We had a SMILE ectasia last week, 4 years post-op, was 3 years post-op documented on Pentacam, doing extremely well, pristine cornea, nothing. In the last 1 year, she's somehow developed allergy. She's been rubbing her eyes and, got went into ectasia.
I think important that we tell all our patients who get LASIK done never to rub their eyes, and I tell that routinely to all my patients. We shall now go on to our next talk on phakic IOLs in high astigmats and keratoconus. Again, I don't think Dr. Kumar, needs any introduction, is a very dynamic, versatile cataract and refractive surgeon and director of the Kumar Eye Institute at Mumbai, and with great experience in the refractive surgery of a couple of decades or more. I shouldn't say more, that makes him older. So on to you, Dr. Kumar.
Thank you, Chitra. I don't like her courses because she gives you the topic and then you have to start scratching your head. So she had added one more thing in this which I conveniently deleted, which was saying phakic IOLs and penetrating keratoplasty. I have experience of none. So I decided to remove that topic from my main topic and keep only two things which I have little experience about.
Keep it for discussion.
Okay. So there's been a great evolution over the number of years and decades. Things have come and gone, changes, and I feel the future in refractive surgery will be surface and smile. Only two things will survive test of time, and I think LASIK flaps, yes, will continue, but not as much. Femtoflaps will continue, but blade will be going out. I just want to discuss one case or two cases, and I'll show the slides. This was a 25-year-old diagnosed with keratoconus both eyes. I still do C3R and Intex. I don't do so much of TREC. No worsening of vision, no change of refraction over the number of 2 years. Corneal topography showed no sign of progression and demanded spectacle-free vision. So the patient had minus 1.75 at 5.5 at 612 and minus 1.25 at 6 at 145, 612. So this is after Intax. Of course, it was a cone which was inferior. After Intax, it did stabilize a bit to some extent and it was quite stable. Pachymetry, as you can see, is 477. White to white is 11.7. ACD is very good, 3.22. And this is after Intax again. You can see the centralization of the cone, which is very, very good.
Timer should be checked, please. Should not be informing you for it. No, you carry.
Okay. So we had a lot of options here as to what we can do. We could have done lots of things. I decided to go ahead and do a phakic IOL. So the central cornea, we know the high order aberrations. Most important is stable refraction and stable topography. So we had this for almost 2 years and no other issues. And this was the pre-op. So you can see post-op, I got a patient with a minus 0.5 and a 612. So aberrations, and you can see the root mean square is 0.38 and root mean square high order aberrations is 0.08. So that's the reason why I decided to go ahead and do a phakic IOL. This is an OCT picture of the same. I had a very good vault and everything looks good. Coming to previews, about a lot of presentations have happened all over the world, and now this is quite an accepted fact that if it's a decentered cone, we can do Intact, centralize the cone, you have a good ACD, patient wants spectacle freedom, then you can go ahead and do an ICL, which is going to do very, very well. Coming to phakic toric ICLs in high astigmatism, this is quite a normal thing because if the astigmatism is high, it's quite possible to do this. But the big advantage I feel why this should be considered is because we're not touching the cornea at all. So all the rest of corneal ectasia are completely gone. It's a reversible procedure. So if the patient develops glaucoma, cataract or anything, we can just remove the ICL. Improved post-operative result. The quality of vision is far better because if you have a thin cornea and you have a high astigmatism, you need to keep a larger optical zone to prevent regression. And you're not going to be able to do that. So if you keep a smaller optical zone in a high astigmatism, then again the results are not very good. There is some amount of regression that happens in such cases. So corneal aberrations are stable, risk of regression is averted. So there are lots of advantages of considering a phakic IOL in such cases. There are enough presentations over the number of years. It's quite time tested. So it's not anything new that we are doing, and it's quite proven. So this is again a 22-year-old stable myopic astigmatism, almost at 12 months, uncomfortable with contact lenses and wishes to have. So 8.5 and 2.25 and a 521 thickness definitely is not going to be eligible for any other refractive procedure. And a white to white of this keratometry was done. We do measure white to white. This is the pre-op topography, and the ACD was 3.12. So even if you have a high astigmatism with high myopia, this is the other eye, again an ACD of 3.11, 8 with 2.25 and 11 with minus 4. So this patients will 100% do very, very well with a phakic IOL. So if you have high astigmatism with a thin cornea, you can do this. Now, what I do is still marking. A lot of people use Virion. You can still use Virion if you have it. There is nothing wrong in that. Again, the placement can be done. Once that is done, we can double check if necessary sometimes, and that's how I do the marking to make sure that we are right. And sometimes I also mark the incisions. There are two ways I always inject at the methyl. You can also do irrigation through the side port and put the IOL inside BSS itself and remove the step of washing at all. So here I like to inject in the same axis. You can see this is a plate haptic design, which is like the star design with a central hole. and we align just the marks that is necessary. So high astigmatism, this is just 10 degree of placement, so there's not much rotation from the 180. Once one side of the plate goes behind, the other side of the plate goes behind. Any methylcellulose I like to wash with Simcoes, the old our favorite Simcoes, and that you can even go beneath the lens. I just keep irrigating and it just keeps flowing out. If you want to avoid this, Gaurav injects ICLs under irrigation itself. I've tried that, but somehow I was not very happy because I was not having control, and sometimes the patient feels the pressure of the water. I don't know, Gaurav will like to tell us more about injecting ICLs under irrigation itself and nothing else. So sometimes I'd like to press the ICLs to remove the methyl from behind, and you can even go behind the ICL, just irrigate fluid and that will remove all the methyl. Of course, we give acetazolamide post-op for 3 days, and that controls the IOP quite well. So as far as toric ICLs in high astigmatisms with a 11 with 4 with a Pacquiao 521 does give excellent results. So as far as my experience with Intacs and ICL is very, very good, and of course ICLs per se is very good. I have some experience with Trek, but it again has some limitations. So in the past I used to do without Trek. I used to just remove half the amount of refractive error on the cone and then treat the rest. So as far as Scheduloplasty, I'm just going to show why it should be considered post-op astigmatism. Of course, high enhanced Hyperopia between the two eyes. There are some articles published. So I have zero experience in this. I've never done this, but this is just some articles published that phakic IOLs are very effective in high correction because of DALC or any other procedure the patient has undergone, and of course has a very high amount of astigmatism. So this has been published over time, and it is proven that it works quite well. So multiple studies have evaluated safety, efficacy of implanting in post-Scheduloplasty, bearing in mind that certain patients do wear contact lenses is an option for such patients, but there is a risk when you wear contact lenses in such cases. Thank you all for your attention.
Thank you. I would definitely take 2-3 questions. One very simple question I'm going to ask Shreyas. Can two patients with the same white to white have different sizing of ICL?
You mean different sizing as in our measurement or the IOL size?
ICL size.
ICL.
ICL size. Yes.
There are the factors are white to white and anterior chamber depth. So whether it's a very deep anterior chamber depth or a shallower anterior chamber depth, you'll have to choose it accordingly to the
And
white
also
to
the corneal curvature could have been different. So even if the white to white were the
Curvature is
same and the AC depth.
Curvature won't
That
affect.
is not a
Curvature will not
factor
affect,
at
it's
this
the
point of
ACD.
time.
But then if you're doing if you're using the same online formula
Yeah.
and you use the white to white and the ACD for the same refractive error and white to white, you can have different lenses depending upon the ACD.
ACD, not on
But
the
if you're using UBM again, it can be it depends upon what is known as the lens rise.
Yes.
So how much is the lens equator above the line connecting the ciliary sulcus to ciliary sulcus. So that can also influence the sizing of the ICL.
It'll influence the final vault. So
Vault,
definitely,
yeah.
sir.
You have any
A quick question on the phakic IOL in KC, sir. Do you feel centered versus decentered cones? Does it make a difference?
Yes, big difference.
So you don't
Even
do a
it will
decentered
be the
cones?
same application in even IOLs.
Correct, sir. No, but you say a strict no in decentered cones.
Strict no.
I would do a no. I would do an Intacs single
No,
ring.
if I'm talking
then-
about
No, he's-
topo guided or Intacs, but now patient is stable and this thing. Do you feel topography
always
should be a greater?
More than topography, I look at the best corrected vision. If the best corrected vision is better than 612, then you can go ahead with an ICL. If it's 612 or worse, I don't go in with an ICL. I probably do an Intacs or a topo guided and followed by an ICL.
Even with the rose scale lens on top of
No,
that.
that if the BCVA is poor or
Poor,
best
yeah.
spectacle corrected visual acuity is poor. We just did a recent analysis, sir, of 150 eyes where of keratoconus patients. Though this was not the research question we were looking at, but on a post-hoc analysis when we were looking at data, there were cones which were centered, cones which were decentered, but with good best spectacle corrected visual acuity. And we did not find any difference in outcomes, residual power, astigmatism, whether it was centered or decentered, as long as the best spectacle corrected visual acuity was repeatable, the refraction was repeatable, and patient was happy with that best spectacle corrected visual acuity. Definitely better than 612 like Sir suggested.
But I agree with what your analysis may be, but I'm looking at long term. So these patients ultimately will develop a cataract, okay? And when they do develop a cataract, to have an intact inside sometimes is better than to not have an intact inside. The reason being, a central cone in a cataract with an IOL will perform very well. So I've had a decentered cone in a VVIP. I suggested a 72-year-old keratoconus. I suggested intacts with IOL over time, right? They went because they're big donors to a very big institution in South India, and obviously 72-year-old was not suggested to have intacts, obvious for reasons. It's not going to progress, the cone is going to be stable, and suggested I do only an IOL, and the patient is not happy. So point here is that I have had patients where I've done intacts, that centralizes the cone, the quality of vision improves, as you said, the best corrected, and then go ahead and doing an IOL is a much better strategy.
And for decentered cone, I would prefer intacts over TopoLink, because TopoLink works better in axial cones than decentered cones.
Yes.
Just a quick point, sir, because in cataract and phakic IOL are a little different, because in cataract we don't know what the exact BCVA is. I mean, what has gone down because of the cataract.
Yeah.
So if the patient had a poor best spectacle corrected visual acuity before the onset of cataract, they would still be dissatisfied after the cataract surgery. Whereas with our keratoconus patients, we really know what their best spectacle corrected visual acuity is, what they are likely to get. So I think that way IOL, I agree that it might be a little unpredictable, and in an earlier cornea session we were discussing the same thing, that for a toric IOL, unless its keratometry is repeatable and consistent, we would not even consider a toric IOL, put in a spherical IOL and ask the patient to wear contact lenses post-op. But otherwise, for KC patients, I mean, I'm not saying intacts is not good, sir. Intacts definitely can be done and can be used. But previously we had this notion that slightly decentered cones avoid phakic IOL altogether. But now seeing that as long as the best spectacle corrected visual acuity is good, the patients are able to accept.
In your study of
because more than decentered or axial, it depends upon the morphology of the cone. If you have an MS39, it gives you the morphology of the cone. Looking at the morphology of the cone also will determine how much the best corrected vision would kind of be there after a particular procedure. So it's not only the centration, decentration, the morphology of the cone, how the cone is a nipple shaped or a different kind, there are different morphologies. So depending upon the morphology, that would influence the best corrected visual acuity. So apart from just decentered and centered.
So MS39 is a machine, some of you might know, it's sold by Schwind, but only question here was, even if you do a morphology, it's made by CSO and it's calibrated, it's linked to Schwind also now.
Okay.
So the point here is, even if you get the morphology, you have a decentered cone, say inferior cone, best corrected is say 618, 612. I don't know that if you do an ICL in this case without doing intacts, which axis is the patient really going to land up using?
Just use the refractive axis. That's
always.
Always.
Blindly the patient will use refractive axis.
Don't use the
Definitely
topographic
not
axis.
the topographic axis.
If
Oh,
you
that
use
I
the
understand.
If
That
you use
I
the topographic axis, you will be in trouble.
that
Always
is
use the
in trouble.
refractive axis, best corrected vision, and then do it. If it's better than 612, patient will be happy. If it's 612 or worse, he will be unhappy.
Then better to do intacts.
But yeah. Anyway, I hope people do change their thoughts about what they're doing rather than going back to doing the same. We shall now go on to our next speaker, who's going to be talking on managing hyperopia, the challenges and learning for greater precision. And we have none other than Sri Ganesh, who is the chairman and the medical director of Nethradama Group of Hospitals from Bangalore, and again, a fantastic cataract and refractive surgeon, and with innumerable number of innovative products on his name. And on to you, Dr. Sri Ganesh.
Thank you, Dr. Chitra, and thank you for inviting me to this interesting course. Good afternoon, dear friends. So we look at managing hyperopia. I'm not going to go through the list of challenges. Of course, if you look at surface ablation for hyperopia, younger patients, high hyperopia, it is a no-no because you have severe regression because of the epithelial changes. For LASIK, you have hyperopia has its sets of challenges, regression being one, because you're going to remove tissue from the periphery and steepen the center, and the epithelium tends to it's going to hypertrophy in the periphery. There's going to be an epithelial hyperplasia, and then you're going to get regression. Also, the stroma Because of that, you can have stromal regression. There are several studies using cross-linking in younger patients, and this shows better stability. The other challenging is the large angle kappa, which can be there in hyperop. So if you don't compensate for that, you will get an induced coma and loss of best corrected vision. What I'm going to do in my talk is go through what is new for hyperopia treatment and what is coming for hyperopia treatment. And we had an experience of doing SMILE for hyperopia. We were one of the centers in the global study. So I'll go through SMILE for hyperopia and then later on tissue addition, the work which I have been doing. The relax SMILE is for hyperopia is virtually the same as to correct myopia. The only difference is in the geometry of the refractive lenticule, which is designed to steepen rather than flatten the cornea. So the highest area of subtraction is located in the mid-periphery and periphery, whereas in myopia it's in the center. So this requires a transition zone between the actual refractive cut and the lenticule edge to create a gradually thinning lenticule rim rather than a steep edge, so that you have, that's why you have a very large zone and you have to use a medium cone. The first study was done by Walter Secondo on hyperopic flex, and they found that there was severe regression because they used a smaller zone. The second study, again they used a 2 mm transition zone, so it was a larger transition zone, so they achieved a larger optical zone and they found that the stability was better. The Nepal trial for hyperopic SMILE was conducted by Dan Reinstein and Kishore Pradhan, and they had 4 phases: blind eyes, densely amblyopic eyes, mildly amblyopic eyes, and sighted eyes. And this was the first hyperopia in Nepal. This is the geometry of the lenticule. You can have a 6.3 or 6.7 mm optical zone, a 2 mm transition zone, a very large transition zone, a 90-degree lenticule cut, and an 8.8 mm cap diameter. So it's a very large cap diameter. You have to use a medium cone. And it's got a very small clearance from the edge, which is a 0.25 mm, and normally a 120 cap thickness. The central thickness, the minimal thickness, is kept at 30 microns, and you can remove the lenticule through a 2 mm incision. So these were the 3 phases. I will not go through it, but what they found was centration. When they compared this with hyperopic LASIK, and they found that the offset magnitude was less for SMILE than LASIK. That means the centration was better for SMILE, centration on the visual axis, than with LASIK. They also looked at optical diameter, and they found, and the amount of change in the topography, and they found that you get the same amount of steepening in the center, the zone, with a 6.3 mm SMILE as compared to a 7 mm LASIK procedure. So with LASIK you have to use a much larger zone to get the same effect. And they looked at spherical abrasion of SMILE versus hyperopic LASIK, and spherical abrasion induced with SMILE at the 6.3 to 6.7 mm zone was similar to a 7 mm zone for LASIK. And these are the details about the eyes. You can look at the outcomes. Again, this is the efficacy, and they found that the efficacy was kind of similar for LASIK and SMILE. This is a comparison between LASIK and SMILE, and you can see that corrected distance vision about better than the uncorrected, better than uncorrected, 67% in SMILE and 50% in LASIK. And safety also was very similar to hyperopic LASIK. And the accuracy, again, if you look at the accuracy and the points, the scatter diagram, it is very similar to hyperopic LASIK. This is the accuracy, 59% within half diopter correction, and 53% in LASIK. So kind of similar, slightly better in the SMILE group. But what is important is the stability. If you look at the stability is slightly better with SMILE than with hyperopic LASIK. So it basically induces less aberrations. The aberrations are less. You get an effective larger optical zone, and the stability is better when compared to hyperopic LASIK. The results are kind of, visual results are similar. And these were the 8 centers where the multicentric trials were done, 374 eyes. The results are being published. I will not go through the criteria, but I'll show you a video of how the hyperopic smile pattern is. So you can see that you have the transition zone, then it cuts the central optical zone, and then the side cut, and followed by the cap cut and the axis incision. So it creates a donut pattern where it removes more tissue in the periphery than the center. The center is 25 to 30 microns thick. So the mid periphery is thicker, and the dissection technique is the same as for myopic smile. The only difference is because this is a very large optical zone, you can't use the same dissector. You need a longer dissector. The Reinstein dissector, there were 9 millimeter dissector instead of the 8 millimeter dissector for smile, hyperopic smile. And you can see this is the topography changes. One of our patients, you can see that it's very well centered, and you can see the steepening in the cornea post-op. And if you look at the abrasions, there are hardly any changes. So the profile is very nice. This is the ASOCT. And if you look at the epithelial profile, you get this epithelial donut where you have, which is thinner in the center and thicker in the periphery. This is typical of hyperopic treatments. So hyperopic smile is surgically similar to myopic smile, and it has some potential advantages: elimination of fluence projection errors, truncation errors. Centration is similar, slightly better than LASIK. Achieved optical zone was larger, and spherical abrasion induced is less. I mean, with a 6.3 mm smile, it's similar to a 7 millimeter LASIK, and the refractive and visual outcomes are similar to smile. The other topic I wanted to touch on is tissue addition for hyperopia, and we have done quite a bit of work on this. A recent publication on long-term outcomes have also been published. I'll just show you one case. This is 32-year-old male, and you can see the he has +7, which is a very high hyperop, and these are challenging cases. You cannot do LASIK, you cannot do smile. Best corrected vision improving to 6/12. And this is the pre-op topography, both eyes, right and left. You can see that so normal topography. We used donor lenticules. These are the details of the. We used a 9 diopter smile lenticule, and this is the. I'll just show you. We make a pocket. We program a LASIK with a large hinge. So in effect, you get a pocket, and then you can open up the pocket and insert the lenticule. That's the opening up of the pocket. And then you put in the smile lenticule. Those are some of the instruments which I have devised: a lenticule holder and a T inserter. I'll just show you the video and the post-op topos and conclude. That's the T inserter, which is sandblasted, and you can use this and then just push this lenticule in. The advantage is that it is a reversible procedure. You can center the lenticule to the Purkinje image, which is on basically the visual axis, and then close it. So this is the post-op. You can see that the uncorrected vision is 6/24. There was a little bit of residual sphere, 1.5 diopters. And for this we have a technique called BMR, which is again published, Bauman's membrane relaxation. And this is the paper on that. We use a Barron's Trifine and just trifine the Baumans, so that this provides further steepening of the cornea and an enhancement. So that's the Barron's Trifine. 3 turns on the Barron's Trifine, you go down about 150 microns. We keep a cap of 160. You can also do PRK or thin flap LASIK for an enhancement. But that's this is what happened, that then the uncorrected vision improved to 6/12, which is the same as the best corrected. The residual sphere from 1.5 came down to 0.25 and plano. And this is the topography pre-enhancement. Here you can see that post-enhancement, and this is the difference. So you have steepening of more than 1 diopter with this technique. The other eye, And these are some of the pictures. You can see that the Philly with the BMR, and this is the ASOCT. So this is the two-step procedure using Philly and BMR, which is quite effective to treat very high hyperopia +6 and above. We have treated up till 9.5 diopters very effectively, and this is some of the new work which I'm doing. Thank you very much for your attention.
Very impressive, Dr. Sri Ganesh, to see all your. Shreyas, could you go to the. I'll just take one question because we're running short of time. We have two more speakers. In non-ophthalmic eye, what would be for a hyperopic correction? Till when you would do a piggyback IOL and when you would not?
Piggyback IOL, okay. See, you can have different approaches. You can have a customized IOL where you can manufacture the IOL. You can do piggyback IOLs. You can also use a phakic IOL after implanting a regular IOL. Non-ophthalmos has its special problems. They have thick sclera, they have choroidal effusion, so you have to take a lot of precautions. We put them on atropine, give mannitol, do a sclerostomy, iridectomy, and also a hyalodectomy, and then manage it. I have a video on YouTube, but then you can use even 50 diopter lens in these patients and successfully treated, but it's more of the precautions you take pre-op and intra-op which will determine the outcomes.
Yeah.
That's
Because
a whole
we
different
discussed
talk.
it all, I just wanted an extreme situation to be asked.
It's an
On to
extreme.
you. I would, Shreyash would be showing challenging case scenarios. We are running short of time. I would take your question in the end. And Shreyash, again, as a young, dynamic surgeon, consultant cataract and refractive surgery from Eye Foundation group of hospitals. And I'm sure he's going to come up with very interesting set of cases to discuss. On to you, Shreyash.
So I have just some cases to discuss, and I was supposed to go in the end if there was time left, but since a couple of speakers came late, I got the chance to present. So I'll quickly run through some cases, would like the inputs of all our panelists and audience here. So first, this was a patient where this is a case of smile, where I had a suction loss. Everything was going well. This patient seemed fairly cooperative, was normally, this is the point you lose suction, but everything was fine. But suddenly at this point of time, the patient moved and the suction was lost. But I actually thought the suction was gone. But in fact, it was not, the suction was not gone. The suction had, there was immediately, because there was a sudden jerky movement, and immediately the suction was applied again, but it was a pseudo suction. I mean, the limbus and conjunctiva had gone into it, and there was a pseudo suction. And because there was only 2 seconds left on the laser, the side cut happened because I had not taken my foot off the pedal, thinking it was a suction loss. So this treatment was completed, and as you can see here, this is where the secondary this thing has happened. So I thought, I was not very sure what I should be doing at this point of time. I thought I'll treat the other eye, come back and think about what I need to do here. So I went ahead, and the second eye, I think I was a little more cautious of the fact that this could happen, and the patient, I don't know, for some reason, had almost an exact suction loss at the very same time. But fortunately, at this point of time, when this suddenly happened, I took my foot off the pedal. So I was able to go ahead and just make the incision cut. Mind you, during this incision cut, it's important that you get correct centration, but you have now a full ring available. So you can just center it on the ring which is already there. Even if you're not able to visualize the pupil, the ring is very much visible. So it was very easy, went ahead and did this. So now for the second eye, I was thinking now that since the lenticule is already made, maybe I'll do a circle and then take out the lenticule, because the lenticule had been formed fully. But instead of that, what I thought is, if I, instead of creating a flap, I used the circle software, but created a very large hinge, 270 degree hinge, and just made, 300 degree hinge, and made a 40 to 60 degree side cut superiorly, and accessed it and went ahead and then completed the dissection to do it. So just an example of circle being used as an escape option, if at all you do this, encounter this situation, and the lenticule can be removed. The post-op looks, the day one post-op looked like a smile patient. It didn't really look like what a LASIK patient would have been. So the learning points from this case for me was to definitely take the foot off your pedal as soon as you see any instability in your suction, and that's something which we should do. I think the first case I was caught unawares thinking that in the next 2 seconds the procedure will be over. Ensuring proper centration on redock is very important for your refractive outcome, as well as if your cap cut lenticule cut doesn't overlap perfectly, then you may have a small bit of lenticule which gets left behind, and you'll not get a perfect circular lenticule, and that can also induce a little bit of irregular astigmatism and can use circle as an escape route. Any thoughts from panelists? Anything else you would have done differently?
I've had this situation where where the axis incision has not happened. I think 2 occasions. One, the patient was belling and then had a suction loss, and the laser actually said the treatment is completed,
exactly.
but the axis incision was not there. The other is when I had a conjunctival prolapse, which kind of blocked the axis incision from happening. So everything was okay except the axis incision. So what I do is I take my old RK knife, preset it, and make an incision, and then go in and then remove. I have videos. It works very well. I don't have to use another license, otherwise you lose a circle license, which is the same cost as a smile license.
True, sir.
Can you go on to your next?
So the next case is actually quite similar to what Sir showed for Hyperopia, and I just thought there were a couple of points which to discuss and how to manage this. So this was a patient with a +7 diopter Hyperopia with a -2 diopter cylinder, and this is the preoperative topography. Unusually so, maybe because of the high cylinder, but the patient in both corneas had posterior steepening on both eyes. Although the amount of central ablation for such a high hyperopia is not going to be much, but considering the extent of regression, I was not too keen. The AC depth was only 1.6, so obviously any phakic IOL was impossible. So really the only options were either to do a clear lens extraction with multifocal IOL, but considering a very young patient, I was not too keen on doing it. So thought of doing a tissue additive procedure. So the steps are very similar to what Sir showed, in the sense we are using a LASIK flap but a very large hinge. This is a small eye, so even though I was taking only a 7.7 millimeter flap, the incision actually came at the limbus. And you can see that bleed there and this thing. Rest of it is quite similar. I'll move on to the other eye also because of paucity of time. One thing I realized is, I don't use any special instruments like what Sir showed. Maybe it's a good idea to use it. But if you use a Sinski, which is what I'm used to using for a DSEC surgery or other things for pushing in a lenticule, the gap here is lesser. It's not like the anterior chamber. So you can't really slide it out so easily. So using a flat instrument like the one which he showed, or using just an iris repositor is a better idea, so that you can push it in nicely. So you can see just a flat iris repositor, and then massaging the lenticule and ensuring that it is completely centered on the center of the pupil on the Purkinje image is useful. Although I did my best to center, if you look at the post-operative period, the refraction was good. The patient was happy. It was just the residual cylinder, and I anyway told the patient that we'll be doing a PRK as a subsequent procedure for correcting the astigmatism. But the patient was quite happy, and we had matched the similar power as far as the smile lenticule was concerned, and this is the AIOC2022 showing that interface gap where the lenticule has been inserted, and both eyes you can see it, and it's almost very difficult to make out unless you do a dilated retroillumination. It's very difficult to even make out the lenticule. However, the centration is not absolutely perfect, as you look evidenced by the pachymetry map and the curvature maps. It definitely could have been a little better. So any tips on what we can do for centration, and as well as for hyperopic astigmatism, have you been able to correct astigmatism also using myopic astigmatism lenticules?
For hyperopic astigmatism, what you do is you correct the astigmatic component with smile. You have a little bit of sphere, like a 0.5 sphere, -0.5, and the cylindrical component, correct it using doing smile, and then you anyway have a pocket where you removed a lenticule, and then you put in the same optic zone lenticule so that it fits well, and that corrects the spherical error. That is something you can do. And for centration, what I do is you have the reticule on your right eyepiece with rings. Okay, so once this is normally a 6 millimeter or a 6.5, and you have a 6 millimeter ring there. The patient is fixating at the light, at the center of the crosshairs, and then you use this circle to center, to match the edge of the lenticule. When you put the ledge, and then you get a perfect centration. The other thing is you can mark the center with ink, but that again, I don't like it because it's there post-op. It may interfere with the vision. But so if you just use the rings on the lenticule in your reticule in your right eyepiece, then you can match it perfectly.
The one which you showed, was it a preserved lenticule, sir, or was it a fresh lenticule?
It's a fresh lenticule. We first published with cryopreserved lenticules, but we found that the reaction is more with cryopreserved. So now we just use fresh lenticules because we have plenty of myopes undergoing smile.
The one which you showed, probably maybe it was a little while longer kept in saline or something, was a little edematous. It was very nice. The edges was very clearly visible. I did smile in a previous
that was a 9 diopter lenticule.
So and one very important question, we have to go on to the next speaker, just not time. What is the lenticule thickness which you use for the correction? Like, how do you calculate?
No, I used a myopic lenticule with a half a diopter additional. I didn't use 2 diopters, sir.
Correct, but the back vertex. See, I do a cycloplegic refraction and use back vertex correction,
distance, yes.
and then it works well. Above 6 diopters, okay, what happens is the posterior changes are more than the anterior steepening, so and that's why it takes away from the correction. So once you do a Bowman's relaxing, then you can see the posterior change. It comes to the pre-op levels. This is beautiful. We have published it. It's there in the JRS, I think, last month's this thing. So by just doing a simple Bowman's relaxation with Barron's Refine, you can.
Okay. I think I'm very sorry because 2 of you were late. We started having more discussions. So make it as brief as possible. 5 minutes for each.
We'll stop with this.
Very sorry.
Shall I stop?
I would. I think again, Dr. Ramamurthy needs no introduction. Is a chairman and managing director of the Eye Foundation group of hospitals. Again, a very versatile cataract refractive surgeon and past president. So on to you.
Topoguided
I'm
treatment.
Extremely unhappy about this, but I want both of you to talk. So
this is how you treat past presidents.
okay, then we'll have more time. I request give us 6 more minutes. Come.
The topoguided treatment has been introduced as a repair tool way back in 2003. Here we are more concerned about the best corrected visual acuity rather than the uncorrected visual acuity. I'll straight away go on to some of the examples. One of the major advantages of topoguided treatment is a bimodal treatment where you are not only flattening the steep part of the cornea but also steepening the flat part of the cornea. The basic principle is where you don't use beyond 50 microns of corneal tissue, and usually always we do it along with the cross-linking so that whatever effect we achieve is retained for the patient. And if there is mild irregularity and a small power that needs to be corrected, maybe both wavefront guided as well as topoguided ablation will work. But if it's a large error that needs to be corrected, topoguided ablation is the way to go. I'll quickly run through some cases. It's a minus 5.25 with a 0.5 diopters. Intralace treatment done way back in 2009. Patient achieved 6/6 vision, but complained of persistent glare and night vision difficulty. This is the pre-op topography, and this is what you see post-operatively. You can see an area of flattening over here, and that's impinging on the central 3 millimeters also, and that is the reason the patient was having dysphotopsia symptoms. So what we essentially do in this situation is to go ahead and do a topoguided treatment, and you find that excellent flattening has been achieved, and you find that this was the pre-operative picture and this is the post-operative picture, and you find that from 37.1 it's 39.2, and the difference between the superior part and the inferior part has largely gone away, and you can see a sea of yellow, because of which the patient's symptoms are significantly diminished. Going on to a case number 2 where we had a epithelial ingrowth, the epithelial debridement was done, but there was significant flattening in that area. That's the reason that you find the significant flattening over here, and which is also going on to the central 3 millimeters, because of which the patient not only had a astigmatism but also poor quality of vision. So topoguided treatment was what was done. You can see this bimodal treatment very nicely represented here. In the steeper area, in the flatter area, steeper area we're flattening it, while outside of the steep area we're putting in some laser treatment so as to steepen this area. And this is what we achieved at the end of the treatment. And this is the comparison maps. This is the preoperative treatment. preoperative map. This is the actual treatment profile, where you see that the flatter area has been, the steeper area has been flattened, and outside of the flat area, we do a little bit of laser ablation to steepen this area. And what you find is that from a 35.1 over here, it has come to 39.8, which almost matches the 39. That's the reason that even though the patient requires a certain amount of myopic astigmatic correction, the quality of vision is excellent, and the patient actually preferred not to do any further treatment. Case 3 is again a optics treatment done way back. In this case, we had a low hinge, because of which not only there was a requirement for glasses, but poor quality of vision. Here again, what you find is significant flattening in this area because of the double ablation that has happened over here, and the residual refractive error. Is not just the requirement of glasses, but the poor quality of vision that these patients complain of. Subsequent to a TCAT treatment, this will become better represented over here. You can see this is the pre-treatment topography. You can see a significant flattening over here. This is post-treatment, where you see, especially in the central 3 millimeters, almost exactly the same amount of 40.3 is what you have in the inferior half and the superior half, because of which not only the refractive error came down, but the quality of the patient that the patient had also significantly improved. And here again, there is a microkeratome LASIK that was done, because we had a free flap. The patient had a significant area of steepening here because of the flap had not been properly positioned, not only requirement for glasses, poor quality of vision. So again, a similar treatment. And here, subsequent to the initial TCAT topography, what we achieved was a significant residual refractive error, though the quality of vision improved. So the patient, since significant adequate amount of tissue was left over, we went ahead and did a second treatment, which was a wavefront optimized treatment to address the refractive error, and then this resulted in a picture like this. So these are 3 comparative maps that you can see. This is immediately after soon after the free flap. You can see a very irregular cornea over here. And then subsequently 3 months later, when we did a post-TCAT, we could reduce it to 48.5, but since still a significant amount of refractive error was there. Finally, when we did a wavefront optimized treatment, we could not only take care of the irregularity which was done by the first step treatment, but with the second step treatment, we could also take care of the refractive error, so that we ended up with a very small astigmatism and a very satisfied patient.
I think we could conclude.
Okay, I can. Thank
Sorry.
you.
Very sorry.
Thank you.
Yeah. Excellent cases, but I mean, poor time management by us, because you all were not there. I'm very sorry.
Rama's used to getting cut off.
And we look forward to our last speaker, Dr. Mahipal Sachdev, who needs no introduction, who's our immediate past president and also the chairman and managing director of the entire Center for Sight Group of Hospitals, an amazing cataract and refractive surgeon, and he is going to take us on a very challenging course, Unplanned Smile Challenges.
Thank you very much, Dr. Chitra, and I'll be going through a couple of videos. These are unplanned smile challenges that it is. Everyone has gone through the smile procedure. There's just a circle scan. I think Shreya showed it, but for enhancement, you just need to do a circle scan. You just still don't have the commercially available smile on smile. So either you can do a surface ablation or you can do a circle scan where the cap is converted into a flap. So it's the only thing which I have is that you have to pay for these treatments. So you're not charging the patient and you pay for a treatment for that. That's the only thing. But apart from that, it's a simple procedure. And you can see that you get this donut kind of a situation. And you can just lift the flap that has been created. And mind you, this is a fresh cut. So the chances of epithelial ingrowth are not there. So it is not a relifting of a flap, but it's a fresh cut. And then you take the patient to the laser and do that. Suction loss, because there is a larger duration, what it is, the newer one, the time is reduced by about 10 seconds, but as things stand, we have about 23-24 seconds. And the suction is not very hard, so you can lose it. I don't know if anybody has covered this or not, but if you are during a lenticule cut right from the start, if you lose suction within 10% of the first cut, it goes back to 0. That means you restart. During lenticule cut, if you have greater than 10% of the lenticule having been cut and you have not completed the posterior cut, then you have to actually convert it into a flap. And during lenticule side cut, you can repeat for the side cut, and during cap cut, you can repeat from the cut. So I'll just show you all these different. So this is suction loss, sorry. This is suction loss at the time of posterior lenticule cut. So you can see that this is the posterior lenticule cut and you have a suction loss here. So what we have to do is at the same time we can make it into a flap, and then you go ahead and do an excimer laser on this particular case. Now this is suction loss. This is during the anterior lenticule cut. So you can see this is the posterior lenticule cut that is happening. So you go ahead, you'll have the side cut which is coming on. You can see that there is some fluid starting to come, and then you have the anterior and you can see this fluid. So ideally you can stop here, but in this case we lost the suction. So I would, because there is so much of ballooning, I would stop myself. You go ahead with the same patient interface, the machine takes you there and you redock, and then you can restart. So you can see that this is restarting of the anterior lenticule cut, and you can go ahead and then, though it is slightly decentered, you can see it is slightly decentered, but this is the side cut that you are having. And in this particular case there is absolutely no issue because it goes in the same plane, and you can go ahead and remove the lenticule, as you can see in this particular case. Now this is a suction loss during the side cut, as Shreyas was showing. So in but this particular case I'll just go forward. You can see this is the you're tending to have this fluid coming in. So this is at this particular time there is a problem that you have in this particular case. So this is the side cut has not been completed, so we make it into a flap. This is the entry cut where you have at that particular time. I'll just go forwards. You can see in this particular case we are just able to do the entry cut. So this was just before the entry cut that you have. So you can make the entry cut again. I'll just go back. So you can see this is where you are having the suction loss. You see, so it was just before the entry cut, and we went ahead and just did the entry cut. This is an eyelash that came in the center. So I have shown this for intralace. This is for smile. Again, you get an uncut area. So please do not let the femto fire when you have debris, and especially a cilia. So this is going to leave an uncut area which is going to cause a problem. This is remnants of lenticule, which you can see. This has been overhyped, I say. I don't think once you are experienced enough you have any of these lenticules remaining, and if your cuts are not proper. So what you can do in these cases is that you could stain it with Tricont, you can put air, you can even use any dye, and you can see that. Another thing is that you can use the slit lamp as you are seeing in this particular case and remove the lenticule fragments that is there, but they need to be removed. This is to just show a microscopic integrated IOCT. This is not SMILE actually, this is the ELITA system of J&J that we are working on, and you can see in this particular case we have marked the centration. So here the MIOCT actually guides you onto the plane. So can you see this? This is going into the posterior plane. Can you see this? It's clearly shown on the MIOCT that you have gone into the posterior plane, and therefore you should have gone into the anterior plane. So you again go and take this out, and you will see here in this particular case this is the anterior onto the anterior. So the OCT can be a useful guide which is there. This is just to show you a very rare complication of having epithelial ingrowth or nests, actually not an ingrowth, but you have nests. So you will have to open it up and clean it up and maybe put mitomycin C and do that. This Shreyas Getansha et al, they have reported this is unilateral corneal, sorry, this is our, so this is just mix up. We have actually reported unilateral corneal ectasia following SMILE, and this is unilateral sterile infiltrate which responded to steroids that has been reported. This is one single case where the other eye in unilateral corneal ectasia post SMILE. So you have to follow the same mandates that you follow for LASIK as you follow for SMILE. So SMILE may be potentially better as regards the biomechanical strength, but do not overstep the caution. And in such borderline cases, we do SMILE Extra, and SMILE Extra tends to work much better than LASIK Extra, which is there. Thank you very much for your kind attention.
Thank you. Just one last simple question. In case of suction loss in SMILE, would you prefer to wait for the OBL to clear, or would you proceed immediately? And the second question is, would anybody in the panel would think of doing PRK in the same sitting, or would you prefer to post it for a different day?
So first of all, majority of the cases I won't do a PRK because you are able to either make it into a flap or you can redo it, and I don't wait for the OBL to clear at all. I just, I don't know.
I think the OBL gives you a guideline
Better
for docking,
slaying.
but
Yes.
then the patient fixation is not good. So what you
Yes.
can do is you just massage the center, so the OBL just clears in the center and the patient is able to see the green fixation light,
Yeah.
and then you can dock, and the edge of the OBL kind of acts as a guideline where you can kind of
Very
center.
rarely we're caught in a situation, would you do PRK on the same sitting?
No, I've never
What
done it, I don't
situation
know.
would that be? I don't know, but basically if you have to and the patient has to go somewhere, but ideally I would wait for the patient if I can't do the procedure at the same time. PRK, patients are really not very happy with that, but if you have to, you have
And
to.
if you have a lenticule cut and you do PRK, the incidence of haze is more. So I
Yes.
don't really like that.
Okay. Thank you very much to all my core instructors and my dear audience. I do hope you all gained something from this variety of talks. Thank you very much. Thank you. Hey, 1 minute, one photograph.